Hello, good morning, good afternoon, good evening, everyone. I am Olive Kochman for the Network for Improving Quality of Care for Maternal, Newborn and Child Health. Welcome to our webinar today. This is a webinar series on transforming care for small and sick newborns, hosted by the Network for Improving the Quality of Care for Maternal, Newborn and Child Health, with the World Health Organization and UNICEF and the Every Newborn Action Plan partners. The series will build on the webinar series that ran throughout 2020, and that series was based on the evidence base published in the Survive and Thrive report on transforming care for small and sick newborns. And this series will take forward new guidance, including the new standards of care for small and sick newborns, etc. And we will run this series over the coming 12 months. We'll share a lot more details of that, but it's my pleasure to welcome you to our very first series. So, over the coming months, we will share some information maybe on topics including human resources, data, infection prevention. There's a huge remit of actions we can cover to share country experience and learning while implementing the standards of care for quality care for small and sick newborns in health facilities. And so today we have a very great panel. Firstly, we will hear from Maternal who will share the standards of care for small and sick newborns. These have been shared before and published last year, but this is scene setting. We want to share these with you, set the base for our webinar series to come. Secondly, we want to hear from the regions. What is the progress in our regions? We are looking to the regions today, of those regions of the highest burden, both of the numbers of small and sick newborns and also of newborn mortality. So we will hear from Dr. Rajesh Mehta, Regional Advisor, WHO Southeast Asia Regional Office, and Assumpta Moriti leading work on newborn care and on quality of care for maternal, newborn and child health at the WHO AFRO. So after that, we will hear about an upcoming toolkit, quite an exciting piece of work with UNICEF and Nest 360, London School, and a broad range of partners working with ENAP. Have been preparing a toolkit, and we will hear insights into that development as a toolkit to support implementation of the standards. And then we want to hear from you in part 4. We will have questions and answers. Dr. Gagan Gupta, Health Specialist at UNICEF Health Quarters, will join us for that to help facilitate the questions and answers. So we really look forward to hearing from you in that part of the session. So now over to you, Ornella. I'm going to stop sharing my screen, and Ornella, you please start your presentation. Thank you so much.
Can you see? Not yet. Okay. Hope we are on the correct screen. Yeah, I think it should be like that. Okay, good morning, good afternoon, good evening. I'm Dr. Ornella Lincetto from WHO Headquarters, and I'm very pleased to be with you today to present the standards, to start this webinar series with the standards of care for small and sick newborn. So I don't know why they move. Yeah. So as a background, we all know, so we still the standards are actually developed to try to address the burden of that we still have a very large of millions of newborns who are dying in stillbirths as well as maternal deaths, and but also looking at the standards to be applicable also in fragile and humanitarian settings, and this especially because the majority of deaths are occurring in those settings, and on top of that, because we need to reestablish services after the pandemic. But it's not only important to have a services in place. What the standards want to answer is the issue of providing quality of health services. We know that every year 30 million of small and sick newborns require access to services, but many, about half of these sick newborns, small and sick newborns, don't have access, and those who have access sometimes receive poor quality of care. And among the poor quality of care, there are basic things like lack of running water, sanitation, but also a way of providing care that is expose the newborn or the mother to harmful procedures of lack of respectful care. So WHO, you already know, has developed this vision for every woman, newborn and child, adolescent to receive quality health services along their life cycle and level of care continuum, and the standards reflect of this vision. We have in the new standards adapted the quality of care framework. You can see it to be adjusted to the needs of newborns, including the small and sick, and especially including those elements of experience of care that better reflects the needs of newborns. And the quality of care framework, again, has 8 domains, as you can see here, which are grounded on the health system. 3 are domains that are on the provision of care, which are evidence-based practices, action information system, functional referral system, adjusted, of course, for the newborn, you will see. And then 3 are on the experience of care, again, communication and participation, respect, protection, and fulfillment of newborn rights and dignity, and then the emotional and psychological support and the developmental support that is, again, reflecting the needs of babies and families. And then 2 support, let's say, domains, which are the human resources and the equipment and supplies. And similarly, we have this framework for the standards of small and sick newborn, but as you know, we had also standards for the maternal and newborn routine care published already in 2016, and the standards for the children and adolescents. Now, for the taxonomy and structure of the standards, as I said, that there are 8 domains, and for each domain, there is a standard statement. But under each of those standard statements, under each of them, we have 3 quality statements, with many quality statements developed for under standard 1, because we are trying to address in these standards all the conditions that a baby can present when he's unwell or premature. And then under each of these standard statement, there is a set of measurements, input, output, and outcome measures. So to go a bit one by one, briefly, we have standard 1 is on evidence-based practices. So we have put in these standards under chapter A, if you like, all the care that we had, the routine care, so the standards that were already standards that were developed for the maternal neonatal standards, you can find them here under this chapter. And then we have new chapters which are on the care for small and sick newborn, covering respiratory condition, nutrition condition, care for different type of neonatal condition, monitoring and supportive care, pain management, and advice at discharge. And for example, we had to identify new standard statement, we put the new in red, and here's is the example of the standard precaution that has been added exactly because of the need is very clear because of the pandemic. And here's an example of what the measures look like for quality statement 1. So you have inputs that are more related to guidelines, protocols, operation procedures, and so on. Then quality measures related to outputs that are more related to staff capacity or to equipment and this type of things, organizational kind of stuff and process. And then we have outcome measurements, like, for example, the proportion of newborns who have a certain condition. Then on the health information system, we didn't put the new statements, so you will find the same that were already there on the need of having medical records, on having systems that are functional for collecting, analyzing, and using data on newborn health as part of monitoring performance and quality improvement, as well as system for providing feedback, including on the perception of families on the care they receive. On standard 3, we have some new statements, and I would like to highlight all of three. I would say the first 3.4 is on having the health facility linked when newborn care is provided, linked to a network, part of an integrated newborn care network with a very clear pathways. So, in order to provide better functioning, better referral in case of need. The other standard 3.5 statement of 3.5 is more on how the care is, this referral care is provided. So the need of experienced staff, qualified personnel, and possible also specialist transport teams and transport vehicles to have a better quality of referral. And then the 3.6, also quite new, but very feasible, which is to transfer the baby who requires referral in Kangaroo mother care position with their mothers whenever possible. Then we have active communication and participation, which is very important, as well as new standard statements recognizing the importance of communication with not only with the parents, but also with the baby himself. So the one is on the capacity of recognizing the newborn cues and behaviors and include this in the decision for care. Another 4.5 is more on the interaction with the parents and make the counseling and information of parents possible. And the 4.6 is also new on the need in humanitarian fragile settings, including pandemic, of providing specific psychological and practical, responding to the psychological needs and practical needs of small and sick newborn and cares, because sometimes they are forgotten in this situation. Then standard 5 again is on respect, protection and fulfillment of newborn rights and preservation of dignity. And here we have expanded a bit with new statements, particularly highlighting the new. I would like to highlight the need of work more on the birth registration and identity of newborns, as well as on the registration of deaths and stillbirths. Then standard 6, also we have a number of new statements, because we wanted to integrate a bit in a nurturing care framework in these standards, which was not reflected very much in the maternal and neonatal standards. So we have put here a standards on for preterm and overweight infants to receive Kangaroo mother care as soon as possible. We think that is one of the best way of, not we think, but the evidence shows that is one of the best way of providing a family-centered integrated care that is very responsive to the needs of the preterm baby. Then the standard statement 6.3 is on the development supportive care, also very important, because as well as recognize family as partners in care. So again, something that was not present before. And then the 6.5 is more on all babies to receive appropriate and coordinated follow-up, which respects also the family life and routines. So these standards on the experience of care are very important, because they recognize, are based on the evidence on how the environment impacts on the development of the brain of the baby. So with more reflecting also evidence on long-term outcomes, which depend a lot on the quality of care that is provided. Then standard 7 is key, and we will have a webinar only on this topic, which is the availability of competent, empathetic, multidisciplinary human resources. We have, we added one statement that all the staff working in neonatal units should have necessary knowledge, skill, and aptitudes to provide the care as we recommend in the standards, basically, and including ability to interact positively with the newborns and with the carers. We think that is one of the areas that requires a lot of investment, and evidence shows that the level of survival of small and sick newborn in health facilities really depends on the number of qualified staff working per shift. So that is very important area. Then standard 8, of course, is on essential physical resources for small and sick newborns. And here I highlighted only the 2 new standard statements that we have put here, but they are, of course, the ones we had before are still valid. So, but particularly here, I would like to highlight the importance of having dedicated areas for providing in space for providing the care as we recommend in these standards, which is family-centered care, kangaroo mother care, privacy for the mothers to be able to provide breast feeding, and so on. And then also a new statement which recognizes the importance of having also in a humanitarian fragile setting the provision of a safe and secure environment for the care of this small and sick newborn, and the importance of including this population group in the preparedness, response, and recovery plans. So for implementation, we are already discussing and proposing a kind of implementation approach that is, I mean, it's already ongoing, let's say, in the quality, equity, dignity priority countries. So we have, you can see here the 3 steps that have been taken by these countries already, because they've started with the maternal, neonatal, and child standards. So which are steps that goes from the national policy and strategies to build additional partners to support and review the data, etc., and to the step of implementation, local implementation on pilot districts, where the different, the support, the learning, the measurement, the community engagement, and the program management come all together. And then finally, the measurement of the impact, because, and as you know, there are, all of that is already shared since a couple of years through the network, and the Quality of Care Network, which is also the one that is helping us with these webinars. Now, there are also tools that are available that can be used to support the implementation of these new standards. These tools are, of course, some of these tools are being used and are useful also for other components, other population, maternal care, child care, but I encourage countries to look at them as well. So, for example, assessment tools, so the implementation guide for the different levels of the system, on engagement of the community, etc., as well as the new document on the human resource strategy, which is specific for our area of work, small and sick. But more can be learned as we go on with the different webinars. So, in conclusion, these standards for improving the quality of care for small and sick newborn are actually try to define and standardize the inpatient care for the newborn. In this way, it is something quite new. And they can help to organize, plan, and deliver quality newborn care in all contexts. I mean, in stable as well as in humanitarian situation. And you will see in the discussion over the webinar how these are implemented. How our region, especially the Southeast Asia region and the Afro region, are already starting to incorporate or planning to incorporate the standards in their program, in their program. And then finally, we need to address progressively all the 8 domains of the quality of care framework through the standards and through actually if you want to expand access to quality neonatal care services. And again, you will see in the webinar how the NS360 and the partners are addressing systematically this 8 health system building block and the requirements that are need to be in place in order to expand the services. Thank you a lot. I stop here and I stop sharing to hand over to the next speaker.
Thank you so much, Ornella. And now we begin part 2 on the regional implementation, progress and challenges. And Dr. Rajesh Mehta, Regional Advisor, Newborn, Child and Adolescent Health, WHO Southeast Asia. Please, over to you.
Okay, thank you. Thank you, Olive, and thank you, Ornella, for setting the stage. So in the region, what we are doing is, my presentation would inform the situation in the region about the newborn health and mortality, and also about the challenges we have, and then how are we using these or propose to use these new standards into our practice at the country level. So our case is that by now we have done well in the region. We have seen 51% reduction in the neonatal mortality rate between 2000 and 2019, the latest estimates, which is more than the global reduction in this period of 43%. This is in comparison to under 5 mortality. Under 5 mortality has declined faster, as in many other regions. We achieved 63% reduction compared to the global reduction of 50%, again between 2000 and 2019. This 50% reduction is in the stillbirth rate. There again, we have done a little better in the same period, 2000 to 2019, compared to 33% global reduction, we achieved 50%. But our issue is that among 11 countries, there is a huge dispersion of this neonatal mortality rate, varying from as low as 4 to 22 per 1,000 live births. But we are happy that at least 5 countries in the region have already achieved the level of 12, which is 2030 SDG target. And we believe that if the annual reduction rate continues, we would be just about to reach the target in 2030. But the trouble is that we have the pandemic sitting with us, and that may have pushed us back. So all of this progress may be at risk. As we know from our data and from the global experience, preterm maturity, the complications is the topmost cause. In our region, we have a special case for small babies because as you see this in chart, 3 countries in the region actually have exceeded preterm birth rate compared to the global rate, which is reflected by this red line. We have additional problem of low birth rate in our region. So 4 countries actually have much higher levels of, especially the highly populated countries, Bangladesh, India, higher level of prevalence of low birth rate compared to the global average. So overall, compared to some other regions, prematurity complications contributing to as much as 42% or 41.5% of total neonatal mortality. And also to note that between 2000 and now, preterm complications as cause of death in our region has increased from 32% to 42%. So this proportionate increase is because of reduction in other causes, especially the birth asphyxia and the infections. But preterm maturity remains the top. So agreeing with the evidence and this analysis of the situation, the countries have agreed to focus on care at birth for neonatal mortality reduction. So we are looking at both coverage and quality, and we believe much of the acceleration in newborn mortality will come through quality improvement. So similarly, there is an agreement with all 11 countries to focus on care of small and sick babies, both at facilities and also at home-based newborn care, where additional care is required for small babies when they go home or when they are delivered at home. So when we assess the readiness of countries in our region for small and sick newborn care, we find that all countries have reported they are quite ready. So all these program elements are there: care at childbirth, home-based care, management of low birth weight and preterm newborns, the first level care and the referral level care. Now, if I look at the standards of care, which is reflected now by the global standards, I must say that in my countries, if I look for those standards, they will not be available as a booklet in many countries. Those infrastructural standards and clinical care standards will be dispersed in several documents of the government. Some will be sitting in the policies, guidelines documents, some in the training packages, some in the standard operating procedures or standard treatment protocols in the facilities for clinical care, and some are sitting in the health information system. So the standards, the national standards are there, and the programs are there. But our problem has been mostly with the implementation. So we know what to do, but we are finding it difficult in how to do it. So therefore, in our analysis, we found three major gaps in our work. The coverage gap, the interventions are not reaching everyone, and the quality gap, interventions are not reaching at adequate quality. And we do not know some of the numbers. Some new indicators are missing, some old indicators do not get valid data. So as an example of country readiness, India is a big country and contributes 75% of my regional neonatal mortality. But they have made a lot of progress in facility-based newborn care for small and sick babies. Look at these state-of-the-art district-level newborn units. These are not level 3. These are level 2 units. And by now, they have met the global target of ENAP, the milestone related to the newborn care. They have at least one unit in each district. And in addition, they have next below level care, primary level care in block level hospital. These are district hospitals mostly. Similarly, Bangladesh has done similarly well. They have now proposal to complete the target of 2023 by next year by ensuring one unit of this kind, state-of-the-art district level newborn care unit, one per each district. They hope to do it by the next year. In spite of all that progress which we have seen, here are the numbers on coverage and quality of the interventions. If you look at my region performance in the institutional delivery, we have done very well. In the last decade, we have seen a 78% increase in institutional delivery. My regional average presently is 76%. Now, if all of them are delivering, many of them are delivering in hospitals, only 45% are reporting initiation of breastfeeding within 1 hour. That's a huge missed opportunity. So it's a reflection on quality of care, non-compliance to the standard of care, that the breastfeeding must start in 1 hour. This one is a new indicator. We have started collecting this in 5 countries, skin-to-skin contact within the first hour of life. Again, a quality reflection of quality of care in the labor rooms. And we find that the regional average is pretty low at the moment, just 35%. Similarly, postnatal care has not doing well in our country. For mothers, it is a little better. Contact in 2 days with a worker. So mothers are doing a little better, but the newborn average is just 40%. So there are huge, contact opportunities which are being lost. And then there are quality of care issues sitting there. And to make it worse, there are huge inequities. I told you there are inequities across the countries. There is so much of dispersion of newborn mortality from 4 to 22 per 1,000 live births. Within the countries, we are in trouble. Look at institutional delivery, poorest quintiles and the wealthiest quintile. A difference of 35 points in wealth inequity. And similarly, rural-urban divide, again, there are large gaps in equity. So we have decided based on all this analysis that these could be our regional action points, and countries have actually agreed. We have 6 high priority countries, and we are constantly working with them with improving coverage, quality, and measurement. For example, we have done policy guideline assessment. Now we are doing a recommendation assessment whether all WHO recommendations have been included in the national guidelines for newborn care or not. There are 2015 onward, there are a series of newborn recommendations, but many countries may not have already adopted. So we want to check that. We have proposed to countries to do health facility survey to understand the newborn care, the structure, infrastructure, whether meeting standards or not. Then similarly, human resource, which is the standard 7 in the global list of standards. And we are using digital resources to train them. Then assessment of quality of care and constantly improving quality. Family participation is has started, but the overall engagement is low. And home-based newborn care, we have just commissioned a survey to understand the policy delivery, the service delivery platform in the countries. We want to strengthen the service delivery platform through policy dialogue and providing them support in health systems, thinking to improve health home-based newborn care. 30% of mortality reduction could come from here. Then similarly, we are acting on data. We have plans to do SRM and CH monitoring framework, including new indicators and looking at missing indicators in the region. And we have prepared a program management training for district program managers to improve the planning and implementation process. So these are the uses of the standards which Ornella just showed to us. We are using those standards to actually look at the national standards and find the gaps in all those 7 standards. We want to fill the gaps one by one, all at once, as much as is the capacity. And we want to continuously measure the performance, which, the standards, the criteria of measurement, which Ornella was sharing with us, the quality statements and the criteria of measurement, those will be very handy to measure the national health system performance for newborn care. And we have done well in quality improvement, at least point of care quality improvement is expanding in addition to the national level. So we have opportunities to use these standards both for maternal newborn health, for at birth care, and SSN standards for the small and sick babies in the SNCUs and ICUs. And there is a clear step in the framework to adopt the national standard, which I described earlier. Similarly, same is required. The standards, compliance to those standards are assessed in the POCI approach, and we constantly want to improve the compliance to the clinical care standards. So this is what we have in the region, the challenges and the opportunities, and we will want to hear from Africa region. So opportunity for Dr. Azumta to share what she sees in her region. So meanwhile, you can shift the screen. So thank you so much.
Thank you very much, Rajesh. Now we go to the African region next. Next, we look at the status of the reduction of both neonatal mortality and stillbirths, also the coverage of interventions, including the health workforce, and the challenges and next step. Next. So looking at our region, we definitely are not doing well. And this is something that is known. It normally sets the precedent for the global levels of neonatal mortality. The African region is made of, the WHO African region is made of 47 countries. And as you can see, 21 of those countries made no progress in the reduction of neonatal deaths. And at the rate we are going, 42 of the 47 countries are projected to miss the SDG goals of less than 12 deaths per 1,000 live births. And this is because the rate of reduction at the moment is only at 1.7%. The annual average rate of reduction. And the expected, if we are to make the SDG goals, should be at least 7.4%. So we are way below or behind. And this is something that we have been talking about, and we really need answers and help so that we can at least make meaningful progress towards the expected goals. Next. Now, when we look at what we do and what has been identified as interventions that can make a change, especially for, at this time, we are looking at the newborns, both including small and sick newborns. We see, for example, if you look at the coverage, it's so uneven. It's way below. For example, if you look at skilled birth rate at 59 and hospital delivery at 57. And when you come to postnatal care at 45, these are areas where we can focus our interventions, yet the coverage is so low. And this is the regional average. When we go to countries, it really varies from as low as skilled care, like 10% in South Sudan, to very high in countries like Mauritius, which are also part of the region. So this is just an average, and yet we can see it doesn't look good, because we expect it to be at least above 80 for every intervention. So we have a long way, and we need to know what to do next. Now, looking at what is going on in countries regarding newborn, including small and sick newborn, countries have done a lot of work. They have policies, they have plans. Many countries, as you can see, have even adopted the newborn standards, not all, but many of them. Some have even conducted assessments, not so many, but looking overall, the region seems to be doing something, and yet there is no progress. So we need to go deeper to see what's happening. Now, looking at the issue of assessment on the care of the newborn, this is an area that we need to do, because we cannot plan effectively if we don't know what we need to focus on, and hence the need to do assessment. And that goes across many of the countries that have given their feedback on this. So we need to know how we need to focus for each country in order to make collective progress for the region. Next. Now, when we look at the several reports from several countries and what they have planned for in their newborn strategies, we see a plethora of interventions, helping babies breathe, in which 26 countries are implementing essential newborn care. That's part, I think the two go together. Use of chlorhexidine, as we know, for cord care. Look at KMC, it's only being implemented in 24 of the 47 countries. When we come to things like perinatal death audit, which can give a lot of information as to action to be taken, it's only being done in 17 countries of the 47. Then we know another area that contributes a lot to the deaths, documenting of birth defects. It's only happening in 7 countries. Then we put a lot of effort and importance into home visit, because we know, for example, the first 1 day is very important. And we have seen that institution delivery is only in 59%, which means 41% of babies are born at home. So when you look at the visit day 1, day 3, and day 7, it's only a few countries that have got the information to report, or the policy, which means they have a documented policy. Yes, we know it's important, but it's not happening everywhere. Next. Other interventions that have been documented to be very important for newborn, small and sick newborn, like KMC. You can see the level at which it's being implemented. Only Mozambique says it has, the coverage is 100%. All the other countries that have reported are implementing at very low levels. So we can see where we can improve, but it can only happen at country level. Even helping babies breathe, which we know it's the resuscitation of the newborn. Only a few countries are doing at levels beyond 50%. So we have a lot of areas where we can see we can focus at country level. Next. Now we know that to implement all that needs a competent health workforce, skill care at delivery, even performing some of those functions that can mean a matter of life and death. Yet in our region, the workforce is quite challenged. Looking at that figure, the distribution Africa has the least or the smallest global workforce, yet the biggest burden of disease. And this workforce is total workforce, not just the one that is skilled for maternal newborn issues. It's a total workforce. Next. Now looking at the kind of health workforce we are talking about in the slide above, we see the distribution. At the MDG, during the MDG era, the threshold was to have 2.23 workers per 1,000 live births. Now with the expansion of the care to cover the UHC packages, it has been elevated to 4.45 per 1,000 live births. And you can see the level where many of the countries are. And this is data of 2018, which does not, the health workforce does not change much. So this can be said, it's the same status even now. Very few countries can say they have enough workforce. Next. When we talk about the workforce, what we saw above is the total workforce, but that which really matters, especially when it comes to resuscitation and the care of a mother or a newborn who needs that individual care, the physician and the nurses, you can see the level. We are a long way. Next. What are the challenges that we have? Now, looking at the various blocks, we have health workforce, health information, like we have said. You have seen what I have shared. It has come from countries. Many countries don't have the data, and yet when they talk, they say they are doing it. So this is a very, very big gap, and I also saw that from Southeast Asia. The data information gap is very big, needing reliable, availability of reliable, accurate, and disaggregated and timely data for action. Then the issue of the health workforce we have just seen, which is what we have. The health workforce is poorly supported. The environment, you find they don't have equipment, they don't have what they need. Even IPC within the area that they work is not there. Then unreliable supply and access to affordable essential medicine. That is something, and equipment. We know that. I know there are partners who are helping deal with that, but we know that is a very big gap. Then absence of infrastructure in health facility. And here we are looking at for personal comfort in terms of, for personal comfort, like for sanitation, and also for care, like for KMC. We do not have, many facilities don't have facilities where they can do kangaroo mother care. Then we have, of course, finances are never enough. And this should come from domestic and external sources. Then, of course, in our region, we have a big effect of cultural and socioeconomic conditions. And those dictate a lot to access, of services and the kind of services they access. And also inability of communities and individuals to claim their rights to quality health care. How many of them are able to go and say, okay, this is what I should get? No, they do not have the voice. And that's a big factor because many people just do what they are told to do. And they have no choice to say no or yes. Next. Now, next step, we deal with 47 countries, like I have said. In terms of the standards for small and sick newborn, we have disseminated extensively to 24 countries. We had a very fruitful meeting where they came out with plans. And we continue to disseminate through webinars using various regional and sub-regional platforms. Now, during the dissemination, countries have decided to take up the adaptation, and they will do it using their various approaches. With partners, we at Afro are endeavoring to support countries for technical support and available finances. And in the next 1 year, we hope to focus on further sensitization and policy dialogue. And this was brought out by countries during the discussions. We will use the approach of the QED, in assessment, policy dialogue, building quality within the Ministry of Health structures, then adaptation, then capacity building, including for quality of care and coaches, strengthening infrastructure, also engagement with the regulatory bodies and private sectors, full harmonization and synergy, and also continuing community engagement. Thank you very much. I now want to invite Joy Long to give the next session. Thank you.
Thank you so much, my sister Assumpta, and really deep appreciation to WHO for your leadership on small and sick newborn care and quality of care. And fantastic to see 200 people here on this webinar, and all in support of a common purpose. So my job in the 10 minutes allocated to me is to speak on behalf of a large team. I mean, I particularly want to credit a very special partnership with UNICEF and notably Gagan Gupta, who is really a lead in the how-to for small and sick newborn care. So in these few minutes, I want to talk about why. Why have an implementation toolkit? How? It's really about the how. We have fantastic policies and guidelines. How do we move more quickly together in practice to implement them and integrate them? I think Rajesh made that point so powerfully. The what, the when, and the who, and then especially all of you, how to join. So Ornella has really highlighted the great advance in having these 8 clear standards for small and sick newborn care. And I think we've heard from Rajesh and from Assumpta a new era within these 2 big regions in CRO and Afro. One has 6 countries, but maybe half the world's births. One has 47 countries, but really a lot of the burden. And all of these countries together have committed to a sustainable development goal and also to a coverage target within every newborn, really with a new focus on small and sick newborn care. We have an imperative, we have things to do, but we have a gap on how to. And so that is the purpose of this toolkit. We actually have a lot of guidelines, amazing guidelines on specifics. And I think as Rajesh and Assumpta both showed, they may be in different parts of the system. Audit may be in information systems, vital registration systems, KMC, what we do with space, what we do with staff. So how do we put that together? And I think that particularly is critical when we come to small and sick newborn care. We've had a journey for newborn care over the last 20 years in high burden settings. We've made progress, still not enough, with immediate and essential newborn care that we see here in these WHO levels of care. But to reach the Sustainable Development Goal target of 12, we have to have more effective small and sick newborn care and that transition, including CPAP. We need this package. It has to be based on rights, but also on effective and safe care, beyond one at a time. And it's quite urgent. So this coverage target that was announced by a fantastic WHO and UNICEF-led event with both Tedros and the UNICEF Executive Director last September, it's only actually now got about 4 years to run. So for 80% of districts to have at least 1 unit. So we can't afford to have all these countries making separate guidelines, learning things that can't be shared, and reinventing the wheel. How do we put this together? So within the 8 standards that we have, many of those need the right space, the right staff. They all need financing. That's been highlighted in the chat. We need more leadership. So to do that, we won't succeed if we do just one thing at a time, one project at a time, one device at a time, one training at a time. How do we get to be more effective, both in our systems approach to this and also in learning from each other so that we can go faster together? So this toolkit has been co-designed with many people on this line, and we're really welcoming inputs from everybody. And it's based on the WHO's 7 health system building blocks. So each of these are ingredients that are necessary to achieve the standards. But I think, as Rajesh showed very nicely, they may also be in different departments. You know, so we're learning deeply that putting devices in place is not enough. You also have to maintain them. But maintaining them may sit with engineering and not just in our clinical services. Data, so critical. The fantastic commentary that Blutter and company led in the last few days in BMJ said that measurement is crucial, but we're not doing well enough with our measurement. So for each of these, we need to go deeper in bringing what we know, but also embedding the newborn health within the health system. We can't do it vertically. So this toolkit is about how do we link to that broader information system? How can we bring things that we already know, for example, about audit? Yes, bring the tools, but also bring the learning, maybe how to address a blame culture. And importantly, one of the big challenges for small and sick newborn care is hospital-acquired infections. So we heard from many that we need a specific focus on how to prevent, how to detect, how to care. So in terms of what is this? Well, we're looking for 2 levels here. One is an online toolkit, which really will bring in many things that are already in different places, but help people to find it in a one-stop shop and learning from each other. And what we will also see then is that we're missing certain tools, certain things that are needed, and how can people work together to do that more quickly. So we really welcome people's inputs and also learning from countries, because that's one of the beauties of the Quality of Care Network, between regions, between countries, and also between disciplines. So to do this, we need lots of different disciplines to work together. And to do that, I like to paraphrase from Gagan Gupta that we can't afford the luxury of doing things one at a time. We actually have to do things simultaneously. So there's a lot of learning from what has been done in India with a huge degree of ambition in going from 10 small and sick newborn care units to more than 800 in a decade. So as we go forward, having something online is not enough. It's also sharing. And we're so delighted that the Quality of Care Network is going to be hosting a series of webinars. We will also be working with a community linked to this toolkit with more than 200 implementers already. And they're organized by each health system building block because it takes different disciplines. Infrastructure, we need architects, planners, and so on, as well as the clinicians who are the more clinical. I know myself, coming from both a clinical and a measurement background, I've learned so much from people who think about space or people who think about devices. And then very importantly, linking across platforms. It's not going to be helpful for going faster across countries if we're all saying different things in different ways. So this is very much in support of WHO standards, partnering with UNICEF. WHO and UNICEF co-lead the Every Newborn Action Plan. And this is linking and in support of that. So you're all welcome. During June, there will be a number of meetings across these different health system building blocks. And I want to end by thinking by the numbers. We have a common goal. We have many organizations and many different roles across those. All of us bring something that is valuable for this, and we can go faster if we go together. There are already many tools and resources on the beta version of this website, but we're looking to people to highlight ones that sometimes just are really valuable but not found. 90 countries across ENAP, more than 200 community members already involved in this. So thank you, those who've already input already. Those who would wish to join, please do contact us, and we look forward over the next year or so in learning together, sharing together, and going faster together for our common goal to reduce newborn deaths and improve quality of care for women and their babies everywhere. Thank you so much.
Thank you so very much, Joy, for this inspiring insight into the toolkit. And there's been a lot happening in the chat box, so I'm going to share without delay to our facilitator for the Q&A. We only have a very short few moments left for some questions and answers today. So Dr. Gautam Gupta, Health Specialist, Maternal Newborn Health at UNICEF, over to you.
Thank you, Olive, and thanks to all the 4 wonderful speakers, Ornella, Joy, Asanta, and Rajesh. As the COVID pandemic runs deep into 2021, it really risks all the gains which we have made in the past years. And we need to stay a step ahead, not only to halt the kind of negative trends which we are seeing, but also to accelerate the progress. And small and sick newborn area is one of the areas probably which can keep us ahead of the losses which we are suffering for the newborn and the mothers in this pandemic. It's so heartening to see 200+ people today, because we need to bring this whole dialogue into action at the country level. So I won't take too much time, but just one thing: we saw 2 major regions today, the South Asia and the Africa, the 2 regions that account for the majority of the newborn deaths. But one thing is different in 2 regions. South Asia has done very well on the institutional delivery, while not so good on the antenatal and postnatal care. While it's reversed in Africa, they have done much better on the antenatal care and the postnatal care, but not so good on institutional delivery. But as institutional delivery is increasing in Africa, it's a right time to ensure that the whole facility-based newborn care is integrated as they scale up the care for mothers at the health facility. While for South Asia, as they try to reach the last mile coverage, it's important to ensure the quality and the equity part. So with this, let's move to some questions. And looking at the shortage of time, I will just give 1 or 2 main questions. Some of them have been responded already in the chat box. So let's start with Ornella. Ornella, it's mainly about the standard 7. What can be done in a situation where government don't locate enough resources for human resources, and hence compromising the quality of care, plus the support for the maternity wards? 2 things to you, Ornella, first up.
Yeah, thank you, Gagan. Thank you, for colleagues, for the question. Yeah, I was trying to answer in the chat. I think we need to disseminate the evidence. We need to advocate and to use strong evidence to show that if we don't invest in human resources, so we have very negative outcomes, which are not only the immediate outcome like neonatal mortality, stillbirths, and maybe politicians are less interested, but also other type of outcomes like reduce, brain capacity, or babies who end up to be adults with the suboptimal development and so on. So that might be interesting, from the point of view of countries. So the importance of, and then also the evidence of the numbers, if you have a better human resources, you can provide better quality services. And there is really a connection we show from the data of Africa, how there is a correlation between the burden and the availability of human resources. So I think that is important, not only for newborn health, and we can use this data also for other areas of work. So the importance of advancing the human resources. So specifically on small and sick newborn, we have published also a document. We will have a webinar on those issues, which is specifically on the options that countries can take, strategic options for strengthening the human resources for providing small and sick newborn services. And I put the link in the chat. Thank you.
Thank you so much, Ornella. The next question is for Rajesh. There are 2 questions, Rajesh, I'm putting to you. One is that the focus on the time of delivery should not mean that we are not looking at the root causes of preterm and the small babies. So what is the WHO's advice in terms of the prevention part? And the second is, have the rates of unnecessary C-section come down in Bangladesh? So over to you, Rajesh, for that.
Yeah, so, the continuum of care remains the full business of ours. Today, we were focusing just on small component. So in all our policies and the recommendations to the member states, the prevention starts much before the reproductive period. So most of the adolescent health programs have included delaying pregnancy, improved nutrition in the adolescent girls, and that leads to probably better reproductive health outcomes. Pre-pregnancy weight is a better marker of birth weight as per evidence. So there are a lot of efforts which are required. So notwithstanding the pandemic, I think the routine work must continue and must restore all the routine care. So much of prevention on social determinant side will take time, but whatever health sector can do in terms of taking care of adolescent girl and then women in terms of health, nutrition and well-being, only then the newborn will have the full benefit. So we are seized of the importance of at birth care for both mothers and newborns. Today we just described the small and sick newborns. Cesarean is a complex issue. So I don't understand the question. In pandemic, the cesarean sections have gone down. But as a strategy, we must work hard with the profession to conform to the standards which are there for both maternal newborn health, which describe the at birth care, and also position statement on cesarean sections. So there is a lot of work there which needs to continue. But during the pandemic, there was disruption of institutional deliveries to some extent in Bangladesh, but it recovered quickly. The cesarean sections have recovered again, but to a little bit less extent than the total recovery we saw in institutional deliveries. So there is a clear risk that cesarean sections will continue to increase unless we bring in some protective behaviors and mechanisms among the profession and the system. So midwifery-led approach, Gagan, would be probably an insulation from unnecessary cesareans in the long term. So therefore, there are several strategies which we are going ahead with, but everything takes time and pandemic has pushed us back, really. We are unfortunate. Over.
Thanks, Rajesh, very clear. And now to Asamta. The question is pretty broad, but if you can focus on it, what are the major interventions that the 42 countries are not implementing in order not to reach the set target for the SDGs? So if you can just prioritize on a couple of things in the next 2 minutes.
Thank you very much for that question. Like I had shown in the interventions that have been adopted by the region, really the region, most of the countries have adopted most of the interventions, but at country, each country, especially the commitment by the government seems to be lagging behind. Because for example, if you are to implement KMC effectively, you really need to invest in both health workforce, infrastructure, and there have to be funds. So all in all, many countries have adopted many of the strategies, but the implementation remains very, very low. And like I've said, and like was said even in the chat, some of those interventions are supported by partners. And when some partners pull out, the country is not able, or the region that has been implementing is not able to continue. So issues like postnatal visit, like you said, Gaga, that in Africa we do very well. No, we are not doing very well. And especially, they say postnatal, they examine the mother, and many times they don't even examine the baby. So for the baby is at 30%, and that's a very important time when the babies need to be checked how they are doing. Things like chlorhexidine has done very well, but again, coverage within the countries, and especially the countries that have high neonatal mortality, is not 100%. So again, the coverage also doesn't do very well. Then data. Information is very scarce. Many times it's not accurate, it's not timely. And here again, we look at where most of the mothers deliver. If it is the lower levels of health facility, the information, you have maybe 2 or 3 workers who are overburdened. So the information they end up putting in the system is not necessarily accurate. So the issue of data, and also to use it at the point of collection, that is an area that really needs to be strengthened so that they can make the decision that will help them. We are starting to come to adopt the POCI, the point of care quality improvement projects. And hopefully going forward, once they identify the issues that they need to deal with at point of care and address them, hopefully we shall see the results. But those need policy level support and policy level investment, which again is really low. So Africa is very good at adopting, but implementing and increasing coverage is very poor. Thank you.
Thanks, Azamta. And what I said was relatively, like, compared to the institution delivery, antenatal care has done much better in sub-Saharan Africa and as compared to South Asia. So coming lastly to Joy. Joy, no one can ask Professor a question, so there's not a question for you, but we all look at a professor for answers. So probably I'm diverting one of the questions which was for Ornella and Rajesh to you, and that is the indicator for the skin-to-skin care in the first hour. Please share the indicator used to track skin-to-skin in first hour. So Joy, if you can speak a bit on that.
Yes, thank you so much. And I think this is something that the toolkit will really try to help countries on within the indicator part. So, you know, WHO is leading a process at the moment to look at the indicators for routine facility tracking. For skin to skin within the first hour, I think we need to ask ourselves, should we measure that separately? So the data show from the ENAP study last year that actually this aligns probably more with breastfeeding and maybe is not necessary or easy to measure. And we can't put everything into routine data. So I think more focus on the breastfeeding is critical, and then measuring kangaroo mother care for vulnerable babies is really fundamental. So WHO will come with recommendations on that. Ornella and I are part of a group working on that. And I think Assumpta made that point too. She's talking about, for example, some things like chlorhexidine that maybe are easier to do get scaled up. We still can't measure chlorhexidine coverage. So in the chat, people have been talking about learning from others who've implemented at scale. One of the most fundamental things is anybody who implements at scale needs to measure at scale in routine systems. And for newborn care and quality of maternal and newborn care, we need to be much more ambitious and also selective in what we measure. So please join the information systems group and discuss this in more detail, because it's a fast moving area, but we need to not predicate on it forever. We need to get to conclusions and get it into national systems within the next few years. So we really welcome inputs. It's so important that we're ambitious and realistic in what we can measure. Thank you so much. And thank you, Gagan, you've done an amazing job.
Thanks, Joy, and to the fabulous 4 panelists, which we are so privileged to have today. With this, I hand it over back to Olive to conclude. Thank you.
Thank you so much, Gagan. So all that's left for me to say is to thank the speakers as well. Thank you, the audience, for your active participation in the chat. We really look forward to you staying with us. There will be a follow-up community of practice conversation, taking forward the conversation today and the questions that weren't answered. You can join that event that's going to be hosted by Save the Children on June 16th and register at that link. As I said, we have upcoming webinars in this series, 1 per month. The final Wednesday of each month we intend over the coming year. So the next webinar will focus on human resources for the clinical care of the small and sick newborn, and the registration link is here for June 30th. So learn more about the series and you can visit the links, click everything. You can find here, we will be sharing these slides and the recording with you by the end of the week for all the participants that joined today. So thank you so much. And thank you again to the speakers for just fantastic presentations.